This is Parkinson's disease case study by Alex Garcia. Starting with the introduction of the patient, we have the patient profile. This is a 69-year-old female admitted to the hospital with fever, cough, and respiratory symptoms. She is to be assessed for pneumonia. Her chronic condition is Parkinson's disease. She was diagnosed with Parkinson's disease 10 years ago. Some of her medical history, her family states she has been experiencing coughing, choking, and difficulty eating. At the physician's office, she was presented with a fever and increased white blood cell count. Her chief complaint is every time I eat, something gets stuck in my throat. I cough and feel like I'm choking. It just scares me. So looking at some background of the chronic condition, Parkinson's disease, it is a neuromuscular neurodegenerative disease caused by the loss of dopamine producing cells in the substantia nigra portion of the brain. And we're going to take a closer look at that next. The exact etiology of Parkinson's disease is unclear. It is proposed contributing factors include a list of genetics, environmental toxins, prions, oxidative stress, imbalance of neurotransmitters leading to toxicity, mitochondrial dysfunction, loss of ability to produce dopamine producing cells, abnormal inflammatory responses within certain cells of the brain, improper response to dopamine within the brain, and increased rate of cell death. So there's a lot going on that causes this Parkinson's disease. Taking a closer look at the pathophysiology, and again, it involves abnormal cells within the substantia nigra portion of the ganglia deep within the cerebral hemispheres beneath the cerebral cortex. So using laser pointer here, we have the cerebral cortex, and this area, purple region, is the basal ganglia, which is this big thing. And here is the substantia nigra. And so the abnormal cells are in this area of the brain. That's where the problem occurs. The neurons within the substantia nigra produce the neurotransmitters dopamine, and there is usually a balance of excitatory dopamine and inhibitory GABA neurotransmitters that maintain slow, coordinated movement, muscle tone, and posture. In PD, there is a progressive loss of dopamine, which causes an imbalance between excitatory and inhibitory communication. The loss of dopamine and the resulting imbalance of neurotransmitters appear to cause the myriad of symptoms. And so looking at some symptoms and the nutritional implications, we are first going to look at the classic symptoms. The classic symptoms include resting tremor, which this is the body continues to move or shake even at rest. We have akinesia, which is rigidity or loss of movement. Bradykinesia, which is a slow movement, stooped posture, mask-like facial features, shuffling gait, which is an awkward short steps. Looking at some other symptoms that include depression, anxiety, sleep disturbances, sensory abnormalities, and pain. Looking at the cognitive dysfunction, this includes problems with memory, inability to complete complex tasks, and inability to retrieve new information, as well as the development of PD, dementia. I have dementia. I describe it as a decline in intellectual integrity resulting in loss of basic brain functions. And so you're losing those abilities to withdraw memories and to complete basic motor functions. And some of the nutritional implications of PD are going to include the classic symptoms. It can be difficult to complete acts of daily living, like getting dressed in personal hygiene, also grocery shopping and cooking meals, as well as eating. These will cause nutritional problems such as inadequate intake, dehydration, a decrease in self-feeding abilities, and motility dysfunction, things like chewing, swallowing, and constipation. So with the classic symptoms of rigidity and bradykinesia and akinesia, it impacts your ability to eat, and malnutrition is a possible consequence of PD, and often it goes undiagnosed and unrecognized, unfortunately. Looking at drug nutrient interactions, the most important drug nutrient interaction is with levodopa or L-DOPA because it utilizes protein carriers for transportation. It competes with protein transportation of proteins, and so this can cause a decrease in protein uptake. Moving on to medical diagnosis. So there is no definitive diagnostic test. Instead, an evaluation of symptoms and responses to treatment allows for diagnosis. These include a display of the classic symptoms of rigidity, bradykinesia, loss of postural reflexes, and clinical response to treatment with L-DOPA. So if we suspect someone has Parkinson's disease and we prescribe them L-DOPA and some of their symptoms decline, this is a good signal that they do in fact have Parkinson's disease. There is a tool called the Unified Parkinson's Disease Rating Scale, and this is a tool developed for staging PD. It assesses detail for cognitive, behavior, mood, activities of daily living, and motor skills. And it's a survey, and based on the score, you're categorized into a rating scale, I believe 1 through 4. Typical course of treatment with PD, since the symptoms of Parkinson's disease are caused by inadequate generation of dopamine in the systemic nigra portion of the brain, treatment for Parkinson's disease is going to be centered around improvement of the supply of dopamine to the brain. And looking at some of these medications, the first one, the big one, is levodopa or L-DOPA, and this provides the precursor for dopamine to compensate for its diminished availability in Parkinson's disease. And so acts as a precursor, increasing the amount of dopamine to be produced and increases availability in Parkinson's disease. Next, we have decarboxylase inhibitors, and these act to reduce the breakdown of L-DOPA outside the blood-brain barrier, resulting in an improvement in the action of L-DOPA. Next, we have dopamine agonists. These medications bind to and activate dopamine receptors in the absence of dopamine. Next, we have COMT inhibitors, which are catechol O-methyltransferase. It is one of 2 enzymes necessary for the metabolism of L-DOPA. When this enzyme's action is blocked, the overall amount of active L-DOPA remains higher. So the catechol O-methyltransferase is an enzyme for the breakdown of L-DOPA. And when you have these COMT inhibitors, it blocks the breakdown of L-DOPA, thus increasing the amount. We have combination medications. Options include both L-DOPA and decarboxylase inhibitors. We also have MAO-B inhibitors, which are monoamine oxidase, and these block central dopamine metabolism and increase overall concentrations of dopamine. So this is going to be a medication that also blocks the metabolism or breakdown of L-DOPA. And when that's blocked, there is an increase of L-DOPA, of dopamine. Anticholinergic medications affect dopamine release, but are not commonly used. So those are some medications that improve the supply of dopamine to the brain. Next, we have neuroprotective therapies and interventions are designed with the goal of preventing or slowing the progression of the disease. And these interventions include substances such as caffeine, vitamin E, coenzyme Q10. This area of treatment is the newest and most controversial, and clinical trials are still ongoing. Another possible typical course of treatment is surgery. These procedures include deep brain stimulation, pallidotomy, and thalamotomy are deep brain stimulation procedures that involve the implantation of a battery device that produces electrical stimulation to the brain, much like a pacemaker used to treat heart arrhythmias. Pallidotomy destroys the globulus pallidus internus to help control tremor symptoms. Likewise, thalamotomy attempts to control tremor symptoms by destroying particular cells in the thalamus. So these are our typical course of treatment. It is mostly used with medications that improve the supply of dopamine to the brain, and mostly with levodopa. So looking at our patient, starting with the patient assessment here, she was diagnosed with Parkinson's disease 10 years ago. She does have a difficulty eating, and some of the medications she's taking at home include the levodopa, a depression medication, citalopram, and medication for GERD, esomeprazole. And her family history, her family, her mother has Alzheimer's and her father had coronary artery disease. The more important one is Alzheimer's because that's another neurological disease. So she does have a little predisposition to neurological diseases. Looking at her anthropometrics, her height is 60 inches, weight 90 pounds or 41 kilograms. Her usual body weight is 110. This was about 6 months ago. Her ideal body weight is 105 and her ideal body weight percentage is 85. Her BMI is 17.6, which would put her underweight. But if we look at her BMI for her usual body weight that was 6 months ago, it would be 21.4, which would put her into the normal category. So she has lost about 14% body weight in the past 6 months, which puts her into an underweight category. Looking at her lab work and some of her biomarkers, starting with sodium, she has high levels or she's borderline high, and this can be causing dehydration and hypertension. Same with her osmolality, which is high, and this is going to impact her hydration status and cause dehydration. Her in and out records indicate net positive, and this can be also contributing to her high blood pressure. Looking at her protein levels, her total protein, her albumin, and her prealbumin, these are all low, and this is going to be a reflection of her disease status. And this is either low from medication nutrient interactions like with levodopa, or it is because of her eating ability causing poor nutritional intake, or it's possibly a combination of both. And so looking now at her white blood cells, which are high, signals infection. And if we remember from her initial assessment, she was presented with a fever. And so she is being tested for pneumonia, but it looks like she does in fact have some sort of infection going on, causing an increase in white blood cells. The other hematology workup shows signs of anemia. And so first looking at her red blood cells, her hemoglobin, hematocrit, and ferritin, these are all low, which indicate signs of anemia. Low levels of red blood cells is the classic definition of anemia, blood loss. And her transferrin, which transports ferritin, which binds to iron, is high. And it's high because there are low levels of iron in her blood. So she has a lot of these transporters just kind of waiting around to transport ferritin. And so having high transferrin is another sign of anemia. Same thing with total iron binding capacity being high just means that her binding capacity is really high. The cells are waiting around to bind to iron, but there isn't a lot of iron in her blood. So these are all signs of anemia. And the interesting thing is, while there is little research showing correlation between Parkinson's disease and anemia, the exacerbations of PD could be causing the anemia because there is a difficulty eating and poor intake. There could be a reduction of B12 intake. So because she's having difficulty eating, she's having poor nutritional intake, and she's not getting some of the nutrients for B12, and B12 is essential for red blood cell production. And that could be causing the low levels. There is also possibility of Parkinson's disease gastroparesis, which is another common thing that could be causing the B12 deficiency. But like I said, there's not a whole lot of research showing this. And so at this point, it's just speculation. Looking at her nutritional assessment, as of right now, she is NPO on arrival to the hospital. She previously ate regularly at home. Before developing current difficulties following, the patient usually ate the following: breakfast, scrambled egg, piece of toast, or English muffin with a teaspoon of jelly. She would drink coffee with 2% milk and artificial sweetener. For lunch, she would have half of a ham or turkey sandwich, 6 to 7 chips, iced tea with artificial sweetener. For dinner, 3/4 cup spaghetti with half a cup meat sauce, 2 to 3 tablespoons of green peas or other vegetables, half a cup canned fruit cocktail, another slice of bread with some butter, iced tea, and artificial sweetener. So looking at this, her dietary intake isn't all that bad, and it is, somewhat balanced. Looking at her other nutritional assessment, tobacco, she quit over 30 years ago, alcohol only socially, and her previous diet history was mostly liquid because solids are hard to swallow. So looking at her nutrition recommendations, her energy is calculated at 25 to 30 kcals per kilogram, which puts her at 1025 to 1230 kcals per day. Her protein is recommended. This is more for healthy patients at a normal BMI of 0.5 grams per kilogram, which would put it at 21 grams per day. But with the disease progression of Parkinson's disease, we do have to plan for weight loss, and she has already shown a 14% decrease in her weight. And so she would probably fall into this category of 1 to 1.5 grams per kilogram, which would put her at 41 to 62 grams per day of protein. Her fluid intake is 1 milliliter per kcal, which puts her at 1025 to 1230 milliliters per day. Looking from her diet history, doing a simple calculation of the patient's diet, she's actually consuming enough kcal and protein, but it is on the low end. And again, with the progression of PD and considering she has already lost 14% of her weight in the past 6 months, her intakes should be increased from what it is currently at to the higher end of the recommendations. Her protein is actually already on par with her recommendations. We would just be increasing her total calories by about 200 or so. And her sugar and sodium intake is both within her limits. Um, her high blood pressure and hypertension is manageable with this amount of sodium intake. And so looking at nutrition diagnosis, I have unintended weight loss related to difficulty eating as evidenced by 14% weight loss in past 6 months. Swallowing difficulty related to Parkinson's disease as evidenced by patient complaints of pain when eating, coughing, and choking while eating. Next, I have chronic disease malnutrition related to Parkinson's disease as evidenced by low total protein, albumin, and prealbumin, 14% weight loss in past 6 months, and evidence of temporal wasting and sunken cheeks. Moving on to nutrition intervention, the first thing we're looking at is diet orders. And so we're going to modify her timing of protein intake to be low at breakfast and lunch for intake of medications. This is going to help with the drug nutrient interactions of L-DOPA. And so when we take medication in between feeding, it helps with the uptake of L-DOPA and it doesn't interfere with the uptake of protein. And doing it this way allows for the medication to work its best during the day when she needs it while she's awake. Or we could implement just a regular low protein, high carbohydrate diet, and this will help with the efficacy of L-DOPA. Looking at the possibility of a dysphagia diet 1 pureed, and this is if she is going to be consuming an oral diet right now. She is NPO, but in the future or any circumstance that she is allowed to consume by mouth, dysphagia diet 1 are foods that are pudding-like consistency, pureed with no lumps. Avoid foods like gelatin desserts, fruited yogurt, peanut butter. Sample foods are pureed chicken, mashed potatoes with gravy, pureed carrots, applesauce, and chocolate pudding. So with the enteral feeding, as of right now, it looks like this is going to be the possible route of nutrition intervention, but we need to wait for the results to come back from the modified barium swallow test. And then it may be advised to utilize enteral feeding with a PEG tube, which is a percutaneous endoscopic gastrostomy tube. And a PEG tube is appropriate because the patient has pain and discomfort with swallowing, but the gut is working. So we will use the gut and implement the enteral feeding with a PEG tube. The percutaneous endoscopic gastrostomy tube is placed directly into the stomach and utilizes the stomach for digestion. Looking at nutrition monitoring and evaluation, for monitoring progress, we're going to check with the patient to assess understanding of diet order, check to see if the patient is complying with the nutrition prescription of lower protein meals and taking medication in between meals. We're going to check the patient's understanding and compliance of the dysphagia diet order, measuring outcomes. We are going to measure the patient's total protein, albumin, and prealbumin levels to see if they are stabilizing. We're going to assess medication tolerance and compliance with levodopa. We're going to measure the patient's weight status and measure the patient's in and out records. Lastly, we have evaluate outcomes and the evaluation of oral intake to decide if enteral nutrition is required, evaluate patients' tolerance to diet, or if any changes need to be made. And we have comparing monitoring data with nutrition prescription or reference standards to assess progress and determine future action. And that concludes my presentation. Thanks.